Proceeding with the differential diagnosis, I want to discuss this visual field first. So in the exam, you are handed out this display, asked to comment on the perimetry. This will be question number 1, and then the examiner will proceed to your possible diagnosis and then your management plan. Nearly all these 3 questions are the key questions in the viva for any investigation that you are handed to comment on. All of you gave very clever and smart replies to these questions. So most of the candidates, when handed this display, they assume that this is left homonymous hymenopia. And this is really not explained for me. Why did you assume that? During an exam, you're not supposed to answer. During the viva exam, you're not supposed to answer. You're supposed to ask. So, if the examiner hands you this printout, don't rush to answer. Just ask the examiner, what about the other eye? I need to see the visual field of the other eye. I need to see the full printout of the visual field. He'll tell you, I don't have the full printout. And what about the other eye? Okay, the other eye is normal. Oh, wow. This is very different now. So, first of all, upon commenting on this is a grayscale perimetry printout. It might be either 32 or 10:2. So you can't see a point of fixation here. As we explained in the literature review, we have the 10:2 visual field and it's a circle. It's measuring 10 degrees. And we have the 24:2 and it's bear-shaped. So it's measuring 24 degrees superiorly, inferiorly, nasally, and 30 degrees temporally. And the blind spot is here. While in 10:2, the blind spot is here, so it's not displayed. It's not tested. The blind spot is from 12 to 17 degrees. So it will not be included in the 10:2 visual field. And the last one is the 32. And this is a circle. Again, a circle. And it has the blind spot here. So which display is this? You need to comment on that. It's a circle. So it's either 10:2 or 32. But you can't see the blind spot. The blind spot, if it's 10:2, it would be here, not displayed or tested, and if it's 32, it would be here. So all of you assume that this is the blind spot, and this is hemifield defect, and assume that the other eye has a field defect like that. Left homonymous hymenopia, and this is right retrochiasmal lesion. What if the other eye showed this defect? Bitemporal hymenopia. Do you think you'll get a good mark with assuming the answer? No. You must determine the fellow eye visual field. So what's this? As we discussed earlier, just a recap, The optic nerve lesions are strictly horizontal, respecting the horizontal meridian. Glaucoma, for example, respects the horizontal meridian. That's why we have the nasal step. And we have the temporal wedge. While neurological lesions, retrochiasmal lesions, strictly respect the vertical meridian. And we have discussed congruity, how similar the fields are. So you need, in order to comment on this visual field, you need to be familiar with the type of the test. You need to ask. Don't assume anything. So, for example, in this case scenario, you started to comment low quality grayscale perimetry, either 32 or 10:2, and depending on the fellow eye visual field. This might be homonymous hemianopia, bitemporal hemianopia, or neurological lesion, or artifactual lesion, artifact. This is a part that we missed here. So it's very common in neuroophthalmology to have a perimetry artifact from poor fixation, from lens rim artifact. This is very important. And even media opacities might lead to this. There is very important differential diagnosis that's always skipped. Enlarged blind spot. So this is an enlarged blind spot. And an enlarged blind spot doesn't need to be circumferential. By the way, this is not strictly respecting the midline. This is crossing the vertical midline. So this is, if this is 32 visual field, this is an enlarged blind spot. And the differential diagnosis of enlarged blind spot, this is chorioretinal lesion. So it might be parts of disc drusen, papilledema, azure complex, acute zonal occult outer retinopathy, multiple evanescent white dot syndrome, multifocal choroiditis or punctate inner choroidopathy. There might be some peripapillary atrophic or myopic changes and artifactual changes. So you need to ask. You don't need to assume anything. No need to make guess answers. This is another visual field, and because it shows the probability plot, you have clear idea where the optic nerve is and the blind spot, and you have a defect here and a defect here. So one of the differential diagnoses is bitemporal hemianopia, but this is not bitemporal hemianopia. This is enlarged blind spot. So we got different answers for these questions. Again, candidates assume that this is combined optic neuropathy and retrochiasmal lesion. Retrochiasmal lesion from the hemianopia, and the horizontal lesion was an associated optic nerve lesion or optic neuropathy. So please don't assume anything.